Hi, this is Brian Kim. I'm going to share with you case number 67 in the best way to do cataract surgery series. This is an average lens density with a big pupil, and you're just going to see my routine cataract surgery technique, including double chop, cross chop, and mechanical fracturing. So using a cotton tip to steady the eye and center the eye, and then I'm using a corneal marker which will help me to center and size my rhexis. Using the cotton tip to continue to steady the eye, I make my paracentesis incision first on the right side and then the left side, and I want to make sure that the incision is parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing corneal incision. This is intracameral lidocaine and then some dispersive viscoelastic to fill the anterior chamber. And this is a 2.4 millimeter metal blade. This is a bibeveled incision near the limbus, stabbing the cornea, tunneling through the cornea. Once I get to the mark, I turn the cannula towards me and then enter. I inject some more viscoelastic to help fill the eye and flatten the anterior capsule for the puncture style rhexis. I puncture, pointed towards me. You can see the capsule split a little bit. So I'm trying to find the edge of the tear there, and then I'm going around. In this case, I grab on the left side and then grab the tear to rotate it counterclockwise, grabbing and re-grabbing as I go, trying to use the corneal marks to help me center and size the rhexis. You can see this is a rather large pupil, and so that corneal mark does help me to size the rhexis so you don't make it too big. After I finish the rhexis, I burp a little viscoelastic, and this is the Capsulorhexis hydrodissection technique. Place the cannula underneath the rhexis edge contra-incisionally, point it down, get a nice fluid wave decompress on the left side, and then point the tip down and spin the lens on the right side. So that's something I'm doing also. I'm trying to make sure I gently prolapse the lens up a little bit. I think that does help mobilize the lens a little bit more. So I irrigate the cornea and then lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma, remove the surface epinuclear material, place the chopper underneath the epinuclear edge out to the equator, point the phaco tip vertically subincisionally, bring both instruments together and crushing the lens. That's the double chop. Place the chopper around the right heminucleus, pulling it centrally towards the phaco tip, crushing it and dividing it, and that is the cross chop. Using a little bit of vacuum to lift that lens piece up, that first quadrant, crushing it with the chopper, crushing it into smaller size pieces, and then emulsifying the lens pieces. Place the chopper around the second quadrant, pulling it centrally towards the phaco tip, dividing it using vacuum to pull the lens piece up, and then sandwiching it and crushing it with the chopper, and then emulsifying the lens pieces. Rotating the second heminucleus in front of me, and then I'm going to place the chopper around the lens piece, pulling it centrally towards the phaco tip, which is in a deep position in the bag, crushing it and dividing it, and then using mechanical fracturing forces to sandwich the lens into smaller and smaller pieces, and then emulsify the lens pieces. Positioning the right quadrant in front of me, place the chopper around the lens piece, using a little bit of vacuum to position it, crushing it and sandwiching it into smaller and smaller pieces between the chopper and a phaco tip, and then emulsifying the lens pieces. So now that the endonucleus has been emulsified, I'm going to remove the epinuclear material from the anterior side to the posterior side. When I do this, that cortex wants to come out as well, but I'd rather keep the cortex in. If I remove the cortex from the central part and pulling it from the center, it will leave a lot of cortical wisps. You need to remove the cortical material from the anterior peripheral edge where the rhexis is. So if I grasp it from the middle and pull it, I'm really pulling it the wrong way, and I'll have a lot of cortical wisps. And so to spare me of that, I just go out, take the chopper out, push BSS in, take the phaco tip out and then go in with the INA handpiece. I'm trying to very carefully remove the cortical material from anterior to posterior. I'm doing the best I can, but it's not that easy when it's just trying to collapse as I activate the vacuum. So you can see all of this fine cortical material, and that happens because with that effective cortical cleaving technique, unfortunately, you do get that cortical wisps unless you peel the cortical material from anterior to posterior. So that is a flaw of the cortical cleaving hydrodissection technique. You do end up getting these wispy lens material. I switch to the polish mode and start polishing underneath the rhexis edge to remove any lens epithelial cells. And then I polish the posterior capsule surface as well. I do see some fine lens material in the subincisional area that I'm carefully teasing off. Again, when I tend to have some fine cortical material that's adherent in the subincisional area, it does suggest to me that there is more lens material in the subincisional space, like in this case. So I'm going to go in with the BSS cannula and pulse the subincisional capsular fornix, and I suspect there will be some lens material there, and of course there is. And so again, when I'm seeing that there's some posterior capsule lens adhesions right in the subincisional space, I tend to have subincisional capsular fornix lens material where the capsule flush technique works really, really well for that. So I inject some cohesive viscoelastic to fill the bag. I'm having a little trouble finding my incision, but now I find it there. And then I'm going to sweep on the left side. And then I'll sweep on the right side, polishing any of the lens epithelial cells that I see. And this is a single piece acrylic intraocular lens. I'm going to inject it into the capsular bag. The leading portion goes within the bag. The trailing portion stays out of the bag. And then I quickly transition to the INA, go in, activate irrigation, make sure both haptics are disengaged off the optic first, go under the lens, tilting it, removing all the viscoelastic from within the bag and underneath the lens or any material adherent to the underside of the lens. Reposit the lens, turning the lens so that the haptics are horizontal, polishing underneath the rhexis edge, making sure I'm getting any little bit of lens material that's trapped between the bag and the lens. And then switching to visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. So this is a pretty standard technique. This is a fairly average lens density, not too dense, not too soft. A really nice large size pupil. I'm able to systematically disassemble the lens with mechanical fracturing techniques. Again, I've switched to this 2.4 millimeter incision, which is much easier to seal. It's not like the 2.6 was hard to seal, but the 2.4 is really quite easy to seal. A little bit more difficult to manipulate with the rhexis because of the smaller incision size. All in all, I'm really happy with this technique and with this incision size and my standard cataract surgery technique. So I hope this was helpful to you, and I thank you for your attention.